Let's talk about beta blockers after a heart attack. My name is Phil Dattilo. I'm an interventional cardiologist, board certified, triple board certified as a matter of fact, and I have quite a bit of experience in dealing with both the acute phase of heart attacks and the immediate treatment thereafter. Recently, a meta-analysis looking at 5 trials that studied use of beta blockers in the setting of someone who had just had a heart attack and was revascularized, and then subsequently was found to have normal heart function in the form of normal ejection fraction, meaning that the squeeze of their heart was normal. This study looked at these 5 trials and performed what was called a meta-analysis. A meta-analysis is a way of statistically aggregating disparate studies, bringing them together, and trying to use more data to get clearer answers. As a general rule in statistics and in studying human physiology, the more patients you study, the more accurately you can represent the truth, right? Statistics are simply probabilities of events occurring. When we look at something like, would a drug reduce the risk of heart attack in the future? Well, if you studied every single human on the planet, you would know with great certainty whether or not that was the case. But of course, that's not realistic. You have to take a study population and then extrapolate the findings to your patient population at large. What meta-analyses potentially have the capacity to do is to greatly expand findings by taking multiple studies of look at smaller numbers of patients, taking their aggregate data, and making bigger conclusions. And that's what this study did. Specifically, this study aggregated 5 other studies that had looked at patients largely in Western Europe. There was some Asian representation as well, and looked to see what the benefit of beta blocker after having had a heart attack, but in folks who still had normal ejection fraction, what would the effect there be? For years, based on research done in the 1980s, it has been essential dogma that we give beta blockers after a heart attack. And this is because in the 80s, when beta blockers were one of the only lines of therapy, really just along with aspirin and oxygen if needed, and then bed rest and recovery for some people, beta blockers did reduce the risk of recurrent heart attacks, they reduce the risk of death. We know that beta blockers are great for a number of cardiovascular conditions. We use them for arrhythmias, we use them for heart failure, we use them for high blood pressure in certain circumstances, and historically, we have used them for heart attack care. It is pretty clear cut that in folks with reduced ejection fractions, where the pumping capacity of the left heart chamber has been affected by the heart attack, giving beta blockers, at least in the year or 2 after a heart attack, does reduce the risk of major problems. Things like dying of heart failure, dying of a ventricular arrhythmia. What's been less certain is what might happen in folks with a normal ejection fraction. And the findings, honestly, recently have been somewhat mixed. This meta-analysis does make the case that beta blockers may not serve any real meaningful role in folks who haven't preserved ejection fraction after a heart attack. Well, why is that? We suspect that some of this has to do with the normal ejection fraction representing good prompt revascularization. So when you come in with a heart attack, our goal is to get the blocked artery open. The heart attack is the result of a lack of blood flow to the muscle, and so the sooner we can restore blood flow, the better the patient's going to do. These days, I'm practicing in northern Colorado. If we have somebody show up who's had a heart attack for the last 30 or 60 minutes, they show up in the middle of the day. Frequently, they will have had pain and a compromised blood flow for less than an hour before we normalize that. In that circumstance, most of the time, their ejection fraction will remain more or less normal. This is a great piece of the evolution of medicine that we can help people so profoundly and so quickly. Not everybody can get in time. For instance, in the territory where I'm practicing, we sometimes have people flying in from Nebraska or Wyoming or the eastern part of the state that's hours away by car. And for those folks, frequently care is going to be a bit delayed. Even with prompt emergency medical response, people may end up waiting a couple hours before they get fixed up. In those folks, it's not uncommon that they're going to have an impaired ejection fraction, at least transiently after the heart attack. Now, that may go back to normal relatively quickly within something like 6 to 12 weeks, but usually there's going to be some impairment there. And we know in those folks that beta blockers are going to be helpful. Well, let's get to the meta-analysis and what did it find. As I mentioned before, the meta-analysis looked at 5 different studies, and in total it aggregated almost 18,000 patients. It was 17,801 patients to be specific. These nearly 18,000 patients were followed for an average of 3.5 years, which is actually a pretty good follow-up period for a study like this. It gives us a good sense of what happens both immediately in the first 3 months, the first 6 months, first year. Usually by the time you're a couple years out from a heart attack, things have really calmed down. Hopefully you're on great medical therapy and back to normal life. Okay, let's look at the primary endpoint. So the primary endpoint was a composite. It was looking at death from any cause, heart attack, and heart failure. This is a little bit different than the standard, what we call MACE, which stands for Major Adverse Cardiovascular and Cerebrovascular Events. But it's fairly close, and it was chosen so that it would be compatible with another meta-analysis done by the same author cohort looking at beta blocker use in folks with a reduced ejection fraction. And so these 2 studies end up being somewhat internally consistent, which is helpful for making comparisons and making treatment decisions in the future. The so-called secondary endpoints were the individual components of the composite. And so that's one of them was death from any cause, one of them was heart attack, one of them was heart failure. Other secondary endpoints that were evaluated were cardiac death. So it wasn't just death from any cause, but death specifically from a heart attack or heart failure, essentially. Unplanned revascularization. So in some cases, somebody comes in with a heart attack. We know that we're going to bring them back in a month or 2 to fix some other problem that we saw. This would have been an unplanned event where they came in with recurrent pain or recurrent heart attack and had to go undergo revascularization. And then malignant ventricular arrhythmias. This is ventricular tachycardia or ventricular fibrillation, which can cause sudden cardiac death. They also looked at safety endpoints. So they looked at stroke and high degree heart block. We know that in some people where the electrical conductivity of the heart has been jeopardized, giving a beta blocker can further impair the electrical activity and actually induce blockage between the upper and lower chambers, and we call this atrioventricular block. This would be the most common reason to require a pacemaker. Let's talk a little bit about the statistical analysis. Personally, this is the most challenging aspect for a practicing clinician like myself to get a handle on. I have some statistical training, taken courses along the way. I've participated in research and helped conduct statistics, or I've helped perform statistical analyses of the trials of the studies that I've been a part of. I can handle basic statistics. Once we get into the meta-analysis structure, things get much more complicated. There are a lot of ins and outs that I frankly just don't have the training to fully understand. This article was published in the New England Journal of Medicine. This is a very well established and honorable medical journal. They have reviewers, including statistical reviewers, that are looking at the data, looking at the statistical analyses, and to a large degree, I have to take it on faith that the statistical analysis was done in an appropriate way and that the findings are logically consistent. I can't realistically go in and try and understand every statistical model and every technique that's being used. It just isn't going to be possible for someone like me. That's true, I think, for most practicing doctors. We all have sort of a working knowledge of statistics, enough to know if something is particularly fishy, but in a complicated analysis like this, we just have to essentially take the author and the journal's words for it. One of the standard ways of setting up a study is through randomization, and so essentially flipping a coin. One person gets a beta blocker, other person gets a placebo. That's how these 5 studies were conducted. When that happens, the first table that gets presented in any given paper compares the 2 groups. It compares the treatment group and the placebo group. And you look to see, is there anything odd? For instance, did one group have a higher rate of hypertension, or were there more smokers in one group? When you get to a study that's including 18,000 people, it's unlikely that randomization failed. In other words, the 2 groups should really be comparable across measurable confounders. Things like medications they're taking, smoking status, other medical problems. The authors did present this data, and there was nothing anomalous across these studies. In terms of being able to apply this broadly, which is part of the randomization, as I mentioned before, this study was largely done in Western Europe. There were some Japanese participants as well. It did not include African or South American or Australian patients to any large degree. And so sometimes we say, we're not sure this is going to apply to all populations just because only certain typical populations were studied. So what were the findings? The primary composite endpoint, which again was a composite of death from any cause, heart attack, and heart failure, was the same in these folks with preserved ejection fraction after a heart attack, regardless of whether or not they received a beta blocker. The incidence of the combined event was essentially just a little bit over 8% in each treatment group. Similarly, the various secondary endpoints showed no differences between treatment with a beta blocker or not, and there was no difference in safety endpoints. So what does all this mean for clinical practice? How is this going to change my clinical practice? The truth is, in the short term, it's not going to change anything. And there's a reason for that. The reason is that in the US, if you come in with a heart attack, we treat you and we discharge you without a beta blocker, whether or not your ejection fraction is normal, the system will get dinged for not using the beta blocker unless we had a really good reason not to use it. Now, there are folks who can't tolerate them because, for instance, they trigger asthma, or as we mentioned, they're at a higher propensity for high-grade atrioventricular block. It's okay not to use beta blockers in those folks, but you do have to document why you weren't using the beta blocker. If you simply don't give it because in your head you're saying, well, they have a normal ejection fraction and they're not going to benefit, at least for now, the hospital system is going to get dinged. That can result in lower payments ultimately, and so that's not going to be okay. We have a similar phenomenon happening with aspirin at the moment. You can look at my much more detailed video to get some information about that if you like. But the short story is the sequence goes from the individual randomized trials to the meta-analysis in this case. It's not always through a meta-analysis that things change. This is sort of a nice instance of a very well-done meta-analysis as far as I can tell. But the study gets published, and then guideline writing committees take up the data. Frequently, there's a multi-year delay between publication of a study and implementation of guidelines. And then after that, payers such as Medicare and private payers are going to follow the guidelines in terms of what they think is appropriate and what they're going to pay for. So realistically, in an accelerated timeline, perhaps a few years down the road, we'll stop prescribing beta blockers for folks with preserved ejection fraction. but it could be as long as 5 years before standards really change. Now, is it the end of the world that somebody gets a beta blocker after their heart attack with their normal ejection fraction? No, it's not. Again, safety signals were looked at and there was no difference, so it's not the beta blockers are causing harm. In my experience, the biggest issue with beta blockers are just the standard side effects. They fundamentally block the sympathetic system, the adrenergic system, the adrenaline system, whatever you want to call it. They blunt the effects of adrenaline on the heart, which in the short term after a heart attack can be detrimental. Fundamentally, what we're doing with beta blockers is we're suppressing the adrenaline response. Well, what happens there? People get fatigued. They feel like they can't exercise the way they used to because they can't get their heart rate up. For some folks, it can trigger depression. For the typical 55 to 65-year-old male that comes in with a heart attack and probably has some other vascular issues going on, we give them a beta blocker and all of a sudden they're impotent, and they really don't like that. After a heart attack, there tend to be a lot of mental health issues that follow. All of a sudden, people are coming to grips with their own mortality, and so the depression thing can be real. You layer on some impotence on top of that, and man, you can have some real trouble. People just really don't like their beta blocker. So it's not uncommon. I've been stopping beta blockers after maybe 3 months of use. Going back to my point about what might happen in clinical practice, if we really feel strongly about the issues with giving beta blockers after the heart attack with preserved ejection fraction, it could be that folks get a short course prescription, something like a week, just so that it's documented on discharge, and then they're basically off of it immediately. So in conclusion, this was a well-done meta-analysis done by well-respected authors showing pretty clear signal that beta blockers probably don't have a role after heart attack in folks specifically with preserved ejection fraction. They very much still have a role in folks who have other indications such as reduced ejection fraction, folks with atrial fibrillation, folks with heart failure, folks with ventricular arrhythmias. All those people are going to remain on the beta blockers, and some of them for a long time. But there almost certainly in years to come are going to be a cohort of people where we're not going to be using beta blockers anymore. And I suspect that's going to make some people feel better after their heart attacks. I've been Phil Dattilo. I'm a board-certified interventional cardiologist, and I hope we talk again soon.